I'd like to invite Dr. Paul de Reve, General Secretary of the European Federation of Nurses Association, to be the next speaker. He holds a master's degree in nursing science from the Free University of Brussels, a master's degree in statistics from the Catholic University of Brussels, and a PhD from King's College, University of London. He has been serving as the General Secretary of this association since 2002. Welcome, Paul.
Thank you very much. It's a pleasure for me being with you all, and I'm extremely excited to have American colleagues on the other side of the sea. I hope you are all well. Let me first say to all the nurses in the US and in Europe and globally, thank you so much for your hard work. We are all going through a terrible time nowadays. In my own country, Belgium, we have a lot of infections every single day now again, and we are going into the winter. So thank you so much for your work. I appreciate the work of Nursing Now, but also WHO had the Year of the Nurse, and it turned out to be a very tough year for all of us. But anyhow, we are patient care oriented, and I really appreciate you listening to me on this session. Our main aim of the European Federation of Nurses, representing 3 million nurses in the EU and 6 million nurses in Europe, is to influence these 3 buildings. On top of this picture, you see the Council of Ministers. On the left side, you see the building of the European Commission, and below, you see the European Parliament. And although we recognize, and many stakeholders recognize, that nurses are the backbone of the healthcare system, still, it is very difficult to convince politicians, to convince your capital in the US, that nurses, frontline nurses, are not at risk during this COVID time, and more needs to be done to invest in the healthcare sector. And that's why digitalization has been so important for us. Of course, here you can see our top politicians who are now commissioners who are working on COVID-19. This is our priority. And technology, digitalization needs to be very close to us. You have the President of the European Commission. You have here in the picture the Commissioner for Digitalization, which is Danish, and then the Commissioner for Health, which is from Cyprus. But also the internal market, the business, is run by a French commissioner, and so DG Employment for the Workforce is led by a Luxembourg commissioner. These commissioners are all writing EU legislation, and it's up to EFN to help to inspire them with current data. And so strategic partnerships are key, because everybody agrees that health comes first now, especially during the COVID period. And you see on bottom of this picture that people, citizens in the US, in Europe, wherever you are, the most trusted profession are nurses. There is enough statistics, and this brings me to digitalization or artificial intelligence. It doesn't matter. You need the trust of the citizens in order to move forward. If there is no trust, it will be very difficult to implement all the things that we think are beautiful for the end users. It will not be picked up. A good example is, in Europe, there are 300,000 apps, and only a small fraction is used. So all these investments of the industry in the development of everything and innovation gets lost because the end user does not see the value of these developments. So we are, as EFN, involved in 2 big European projects of Horizon 2020, Interoperate and Smart for Health, which are developing one electronic health record for the entire European Union. So that means interoperability is the central discussion of these developments. EFN is involved in these two big Horizon 2020 projects as end user, formulating the end user requirements so that frontline nurses express themselves so that they know the developers, what do the nurses, the physicians, and the pharmacists in this case need. So we need fit for purpose solutions. If this is not the case, the nurses will throw your stuff in the bin. That's how simple life is. The core design is built on trust, as I said already. If not, nobody can scale up. The data collected need to be reliable and valid. You have the sensors on one hand, but the basic nursing frontline nurses will collect a lot of data. And so you can only use artificial intelligence if your data collected are reliable and valid. And don't forget that the nurses are 24 hours on 24 hours at the bedside, 7 on 7, 365 days a year. This is the reality. So treat them well. Invest in nurses and in nursing before digitalizing your sector, because you will need globally 18 million nurses to deploy digital skills and to use your materials. That brings me to Florence Nightingale. 200 years ago, she was in the war situation and she started collecting data. She advised the Prime Minister in the UK to build a better healthcare system. And still today, we are doing this. But it is important to invest in education, in lifelong learning, which is crucial. Nurses need to have the knowledge and the right skills to deploy digital innovation. Secondly, and come again to it, trust. Europe and the US need to build a trustworthy digital ecosystem, an ecosystem of excellence. And I think that the Commission, the European Union, is well on its way to do that. Collaboration and co-creation with industry, with the developers, and with the end user is crucial. If we don't invest in this, we will develop a lot of things, but we will keep on working in silos. And finally, digitalization should be developed to support the frontline workforce, should support the nurses in their daily work, and not increase their workload, not asking them more and more and more to do. So we need a very human-centric approach. So, dear colleagues, this was my presentation, and I'm open to any question from the panel and from the audience. Thank you so much.
Well, thank you very much. That was a very insightful discussion. There's several questions for you. The first one, which is there, is you've done this effort within Europe. When you say Europe, do you mean all of Europe, all the countries, Eastern Europe, Western Europe, EC countries and others, or do you mean part of Europe?
No, everybody, the 27, the 28 member states as it is now, plus beyond the region of WHO Europe, which counts for 54 member states. So in total, 54 member states, but for sure, the 28 EU member states, plus Norway, plus Switzerland, plus Liechtenstein, those who have a contract with the European Commission.
What about the East European countries?
They are all involved, all involved. Those member states who joined the European Union in 2004 are all part of this project.
Okay, so that means Russia is not part of this project at this point.
I beg your pardon?
Is Russia part of this project?
Russia is not part of this project, no.
Okay. The second question is, what are you doing with respect to Europe, telemedicine across continents, for example, telemedicine between Europe and Asia, or telemedicine between Europe and America, South America, for example? Is there any effort in those directions?
No, what we try to do, honestly, is to make sure that we get our own house in order first. And I think we in Europe do not talk about telemedicine, we talk about telehealth. And so the mindset is a little bit different. That means that telenursing comes under it, telemedicine comes under it. But for Europe, it is very important to look first also at prevention and promotion of healthy lifestyles. And that makes that we need health data, which are therefore not only medical data. We need to have the full scope of data included in the electronic health record. So we go beyond and talk a little bit more about e-health services and e-health.
Given the emphasis on quality that you've emphasized, I want to bring an example from the US and let you comment on it, how a similar case would be handled in Europe. There's a case of a doctor who was disbarred from medical services in the US first by one state, then by another state, then by a third state. He goes ahead and starts a telemedicine company in a fourth state of the US. And from there, he's practicing telemedicine. He's also on the state committee on a political appointment, and he's continuing to do his work. How would you think a situation like this would be handled in a European country?
We have at the European Union a system which is called IMI. And this brings all the regulators of all the member states in this system. So we have in Europe 3 million nurses. If one of these nurses want to move to another member state, they need to apply their regulatory bodies through this IMI system. And it is the both regulators of both countries that will analyze the documents. Now, in Europe, we benefit as registered nurses, general care nurses, but also the physicians, also the pharmacists, also the midwives. We call them the sectorial professions. They benefit from mutual recognition of professional qualifications. So if I, as a nurse, want to go and work in Germany tomorrow, I need to go into the IMI system, and the regulator still will check my credentials, and I can move immediately to Germany. This is the system. In case of fraud or in case of a malpractice, there is an alarm system in the IMI system that will alert the member states, all the member states. But due to the court cases, so often we need to wait. The alarm system will go off, but we need to wait until the court decision is taken. You're only convicted if the court says at the end. So we have a very close system. Of course, it is never perfect. I'm not saying that this is a perfect system, but we are used to use it, and everybody uses it, and it works. I hope that this is an answer to your question.
Sure. How long do the court procedures take there for these kinds of issues to be resolved?
It needs to be minimum than 14 days by law.
And maximum?
It needs to be maximum 14 days by law. I'm sorry.
Okay, thank you. Now, on the interoperability state, where do you think, from a practitioner's point of view, where you are in terms of getting records from different countries, given that GDRP is also there? How do you find it from a practitioner's point of view at working in real life?
As a nurse, I am very happy that we move to a patient-centered approach where the patient, or we call it the citizen, has the access to their health data. And it is the citizen who decides who gives on their mobile to which healthcare professions, to which person. And there, I think blockchain can come in as a new development, and I hope that Europe looks at it. But in that sense, I think the main issue, we changed the mindset from the physician deciding everything to the patient deciding everything, and the accessibility to the healthcare data. So if I get an accident in Belgium with my car and the emergency picks me up, they bring me to the hospital, and I am conscious, I can give the emergency nurse access to my mobile phone and my health data. And so we are in this process in doing it, and each member state can have their own electronic health record. It is not an EU rule. Everybody can have their own record. So the interoperability with the EU record is crucial. And of course, here comes in HL7 and FHIR. I'm not an expert at all in this. Also for the nursing profession, the SNOMED is in process in this. So we are still working in progress. So I hope that in 2 more years, 3 more years, we have one electronic health record for all European citizens in the EU, and that through an informed consent, electronic, that the patient can share their data as they wish appropriate to whoever healthcare profession they think. I hope this answers your question.
Thank you very much. Really appreciate your presentation and the answers to the questions. Okay, thank you.
Thank you very much. Good luck.
I'd like to now invite Dr. Prabhakaran Doraj to make the presentation. Prabhakar has a very distinguished record. He is currently the Vice President of the Public Health Foundation of India. He holds professorial appointments in India, England, and the US. He is also head of a WHO collaborating center, and he's an eminent cardiologist. So Prabhakar, you're next, please.
Thank you, Dr. Gupta, for that very kind introduction. So I live in India, and I thought I should talk about India, the challenges and these challenges of public health and the potential solutions with specific examples. So if I have to enumerate the public health challenges in India, it would take away all my 7 minutes, so I'm not going to do that. I'm going to talk about only something related to the health system, particularly in terms of access. And that's where the role of telemedicine, the point of care devices and others come in. So I'll just focus on a few things. Telemedicine is not new to India. In fact, the Indian Space Research Organization, in collaboration with some of the hospitals here, have shown the Amrita Institute of Medical Sciences in Kochi, which is in the south of India in the state of Kerala. They had a mobile telemedicine unit with a satellite, dish satellite, way back in 2003. And they provided services in high altitudes, Ladakh, which is one of the highest altitude in India, and a state of Uttarakhand, which has mountainous peaks and small populations. They managed to provide telemedicine coverage to them in terms of providing consultations from a hospital in South India with somebody talking to them in the north. So having said that, the technology actually simplified further, and the need for these satellite support was really not needed. And so it has moved on. So, but the COVID scenario has created a new normal for us for everything. Lots of things will change. So in the post-COVID scenario, we need to be prepared, and there are several disruptions that may be needed. In terms of the patients, we need to improve their access through telemedicines and teleconsults. Given that in India, there are lots of people who may not be, who are technologically challenged, and also there are a large number of people with minimal education, we require a blended approach. So we require to have some support from telemedicine coordinators. And of course, there are several other solutions. In terms of, we are going to have vaccines, and that requires scale up. We also need to improve drug availability and distribution, and innovations such as blockchain and distributed ledger technology, cold chain on scale, drug stockouts. These are all things that need to be addressed. In terms of the health system, we need to make it responsive and smart. And we also need to provide assistance to healthcare providers in handling these new technologies. And there are some others. I'm going to just show you a snapshot of what is required, particularly in chronic diseases. So we need surveillance, and that can be done through now mobile phones and tablets. We need to create electronic health records, and there are newer and newer biomedical sensors that have appeared in the horizon, which include wearable devices such as Apple Watch, Google Glass, etc. In terms of screening and diagnosis, to make it more accessible to people, We need portable diagnostic equipment. You can call them as a lab on a chip and portable ECGs. I'm going to leave out all the other high-tech things out of the discussion. In terms of management of diseases, we need electronic decision support system and telehealth and also pharmaceutical innovations. Finally, we need geographical information systems to identify hotspots of disease. We need to build capacity on scale, particularly of primary care physicians and non-physician healthcare providers who act as who provide physician support either through an online mechanism or advanced learning management system. And there are others. In fact, even in terms of clinical trials, these technologies are going to be extremely useful. But I think we need to be very, very careful when we use these technologies. I think quality control is extremely important and it should be scalable. Interoperability, I'm not going to discuss, I'm not an expert, but I think that's the elephant in the room. It has to be interoperable. We have to address contextual needs. India is like of continental proportions, it's like Europe. Each state is different. So you have to, and the disease burden is different. So you need to address based on that context and the cultural needs of those people. It should be easy to use. The cost should be low so that it can be used universally, and we should address the issue of privacy, which is a very important issue in India. I'm just going to show you a few examples of the technologies that we have developed so that you get a feel of what we can do. This is a point of care device which originally did 15 tests, but we are adding 5 more tests to it, including some of the chronic disease variables such as advanced lipid profile and creatinine levels for kidney disease. We are also going to add an ECG to this. It's a Wi-Fi enabled device that works on an Android platform and has several sensors. It's useful for frontline workers for integrated primary healthcare delivery. In fact, it has been tested in multiple locations and it's been deployed in 3 states of India. It has a basic decision support tool to provide screening and triage for various conditions. The second thing that we have done is we have created a software, which is an electronic decision support system. For example, if a patient comes with a high blood pressure to the clinic and his blood pressure is found to be 160 by 100, the nurse or a care coordinator inputs the data from the patient, and this decision support system provides an advice tailored to the patient. So there are around 2,500 case studies, but there is a constant machine learning process over there, and through that you can actually get the patient-centered advice using this system. And this has been tested across multiple health system levels, community level, primary care level, tertiary care level, and we scaled it up in 2 states of India. Now we are evaluating it to scale up across India. We have assisted the WHO in terms of digitizing their PEN package, which is the building block for primary care. And now we are moving towards getting it to private sector and also developing a symptom-based decision support system. These are new things that have been developed. The top portion, it's called Mithai, which means sweet. So we have hit the sweet spot in technology. One of the things that we have developed is for these telemedicine coordinators who are going to be trained, we need to provide them with a kind of modular box in which they can carry vaccines between 0 to 8 degrees or drugs between 0 to 8 degrees. There are some drugs which have to be at 8 to 24, and they have to hold data which is above 24 degrees. This modular box can do all these 3 things. An advanced version of our decision support system is developing a handheld device which can do multiple things, and it can be used for edge AI processing with universally applicable icon software, because we eliminate language over there. So these are some of the things that we have done. So we all know that technologies are reductionists. We are talking about interoperability. So the solutions have to be holistic. And I leave you with this particular complex slide. It's a busy slide, but what it says is we have to address 2 or 3 things. First is we have to address continuum of care. That is from a healthy state to a disease state to an advanced disease state. So from community level to primary care to secondary care to tertiary care, we need to address. The second is we need to look at several domains, including health literacy, health system, health policy, several things, communication and so on. So this requires an implementation framework, and I think interoperability has to be married to implementation framework if you're going to succeed in terms of providing healthcare for all in the next 10 years or so. I end my talk with this. Thank you, and I'm open to questions now.
a lot for your insightful presentation. Um, I would like to start with a question relating to telemedicine. As we have patients in different parts of the country, the hospitals which are serving them, do they tend to be in the neighborhood or they can be anywhere in the country? Like, can a person say from, if you're in Delhi as a doctor, would you be servicing or looking after the needs of people, say in Assam or in Karnataka? Is that typical right now or is it all in the neighborhood?
So currently it is being provided by a few private players. It's not penetrated as much as we want. It is there with three or four providers, and they provide it from multiple places. That's not a problem. The only issue is language. Like for example, if you're in Tamil Nadu and the doctor speaks only Tamil and English and you are going to provide care to Bihar, it might become a little difficult. So other than that, if you take care of the language issue, you can provide it from anywhere to anywhere. But one important aspect is most of the specialist care are provided across states at a distance. Most of the primary care could be provided at the local place itself. Uh, because sometimes the patients may want to see the doctor, they might have seen the doctor, the follow-up could be on a telemedicine mode, and in which case it will be at local level.
Well, what I read a few years ago was that in the state of Uttarakhand, they had implemented a system similar to the 9/11 system where a person could call in for medical help through telemedicine. There are people available who could deal with different specialties, they could deal with different languages. Is that being used as a model? Has it gone anywhere? This was a prototype system that I'd heard about maybe like 7, 8 years ago.
Right. I think each of these states, that's a very I mean, innovative system, I should say. It's like the 9/11 system where people can call 108 and can get consultation, can get advice. So there are different innovations and different kinds of systems which people have used. And I think we need to landscape all these systems
Okay.
and come
Now,
up with.
okay.
Sorry, I actually couldn't hear some of your question, but so I answered from whatever I heard.
Okay, let me repeat my question and see how you. The question I'm asking is that the state of Uttarakhand, I believe about 7, 8 years ago, tried a novel system by which a patient anywhere in the state could call a number. As you mentioned, it's the 108 number. And at the other hand, there were people who were specialists in different areas, medical specialists, and also they were able to speak different languages. So that was a method that they were going to use to channelize it. Uttarakhand, for the benefit of the audience here, is a mountainous state, uh, very rural oriented, population density is low. So I wanted to see how that model has worked out. Is that still continuing or not? That's the question that I had.
Um, it was continuing till a few years back, but I'm not sure what happened. I think one of the problems that arose was there was a big disaster. There was a big landslide, and which created a lot of disruptions to many. So I'm not aware of the. I have to.
Then recently, I was seeing online that Tata Health, being one of the organizations which has advertised that anybody in the country could contact them for a telemedicine consultation. They also made some reference to COVID-19. Uh, in a situation like this, where somebody is offering services across the country, how do we take the cases where a doctor or another medical professional has acted in an improper manner, has done something which should not be there, is being debarred from practice by the local board or local association which is there, but is continuing to practice across state boundary lines? Is the purpose of these boards to restrict the practice at a local level, or is it done at a national level in India at this point?
Right. If I understand the question correctly, you said that Tata Trust
Tata
advertised
Health,
anybody can
Tata
contact the
Health.
board, and the question is with Tata Health. So the question is whether this is for restricting the thing or whether there should be a regulation. First of all, let me answer. There are two or three problems that we need to address. First is it needs to be regulated because there are telemedicine solutions, and there are downsides to some of these, especially in for-profit companies that are handling telemedicine. Obviously, many of the healthcare system in India is chaotic, with almost 70% of the care provided by practitioners. So there needs to be some kind of regulation. The second is, are they creating something like the Kaiser Permanente that also could come up? Of India has come up with the National Digital Health Mission, which has some guidelines. The Medical Council of India has also put out guidelines in terms of telemedicine services. There are regulations currently in place, but I think it will take some time for all of these to get channelized in a proper way.
Now, what about telemedicine across the country? In the sense, there are facilities here like Nighthawk being one of the companies which originally started where they were sending radiological images to India for being read there. Is telemedicine becoming an activity which is taking place across the national boundary lines as well, or is it mostly domestic at this point?
So it is domestic because there is a regulation against providing advice to country like US, because India goes by a rule of reciprocity. The degrees of the US, India is not recognized in the US. You have to take an exam. Similarly, in the UK, it's not recognized, but other countries do recognize. Wherever there is a reciprocity, they can do it. But when reciprocity is not there, it's not allowed. So I would say it is largely domestic. Because if you have to provide telemedicine service to US, you have to be US board certified. If you're based on Indian certification, it's not possible.
Okay, now let's take the scenario where there are people who are US certified. In fact, people are licensed to practice in multiple states of the country. Those were the people in India who were looking at radiological images. Is that business coming along at this point in terms of people having foreign credentials actually working from India to provide these services? Is that an increasing thing, or the growth you see is much more for the domestic sector at this point?
I would say that unless the regulatory hoop is, I mean, you can jump the regulatory hoop, it's going to be a little difficult. But although I know of 2 or 3 people who are board certified from the US who are in India and have a flourishing business in the radiology and the echocardiography and CT scan sphere. So they are doing that. But I see a huge potential within the country itself in terms of providing solutions immediately, especially given the fact that artificial intelligence can rapidly diagnose ECG and can give you a diagnosis as good as a cardiologist. There have been demonstrations in Brazil, in Mayo Clinic and others. I see a huge potential for those kind of activities within the country, because if somebody has the biggest problem now is if somebody has a chest pain, they go to a primary care physician, then the primary care physician asks the person to go and get an ECG done. The ECG is interpreted by someone. The whole process may take 3 to 4 hours and precious time is lost. But if you have these artificial intelligence solutions where you give a low-cost ECG machine to the primary care physician who does the ECG and gets the diagnosis within 2 minutes, nothing like it. You save a lot of time, because time is muscle, both for the heart and time is muscle for the brain too. I mean, you have to treat strokes within 2 to 3 hours. So these are things which are going to be very useful in the future. I see a large domestic potential.
Thank you very much, Prabhakar. That was very helpful.
Thank you.
I would like to invite Mario Highland to be our next presenter. Mario is going to focus on the area of interoperability. He has a very distinguished record. He has worked for over 30 years on sensitive projects, especially in terms of testing of new concepts. He has been affiliated with organizations of the Department of Defense, the Veterans Administration, and other organizations. He's a senior entrepreneur, and currently he is a senior vice president at aegis.net. Mario, all yours.
Thank you very much, Amar. Hello, everyone. For those of you who don't know me, my name is Mario Highland. My Twitter handle is Interrupt Guy. I too want to take a moment and thank you. It's my pleasure to join you here today. And I think that special call out to the frontline healthcare workers that are battling each and every day, one of the largest global threats we have to healthcare with COVID-19. So, special call out to Professor Derive and all the 80 million nurses out there that are working each and every day. So what you're going to hear me talk about today with respect to interoperability is I'm going to try to make it real for everyone. And that is that it's real to the frontline healthcare workers. They deserve our best effort being put forward. We're driving better healthcare, but it requires quality to be built in. And I'm going to talk a little bit about that through interoperability. Yes, there are some technical components. Yes, it's very geeky at times when we talk about interoperability. There are standards out there like HL7 FHIR, and they are viewed as key enablers to allow us to have better care coordination. You've heard a number of speakers talk here today, and I'm sure you hear it continuously around why we're trying to drive better health IT is to make sure that we can provide better care for the patient. To leverage some of that, we're going to have to recognize that quality does need to be built in. And to do that, we can leverage things like behavioral driven development, BDD, or test driven development techniques, which will allow us to accelerate interoperability. Because I want each and every one of you that are taking time here to listen with us today, that interoperability is a serious issue. And it's one that the industry needs to address not only as one item that we're trying to do today, but one item that we're trying to do in a continuous way. So people often ask me, where is interoperability today? What is reality? The reality is that the interoperability that we're talking about today is more of a point in time interoperability. And what we want everybody to recognize is that change is inevitable. Change is inevitable. We're working on standards like HL7 FHIR, which is coming a long way. But there is change to those standards, and we will see it continue to evolve, continue to get better. We as an industry must be able to embrace that change. And we can only do that through what is continuous interoperability. So just a bit about this and just make sure everybody understands it. If the industry is implementing standards like FHIR, and we view that as a path towards interoperability, then why still do so many projects experience challenges and delays? We believe there are ways to enable the acceleration and conformance of these standards and be able to do it in an interoperable way. And we want organizations to recognize that the way we can mitigate this risk to interoperability is through better testing. And there's reasons for that. So when we look at interoperability and we look at enabling these health systems across the UK with NHS, across Europe, organizations like NICTIS in the Netherlands are advancing interoperability with programs like MedMay. They're attracting the industry, they're developing standards, and they're seeing wide adoption. But what are we seeing at the global level when we look at health IT? Well, first of all, the first thing I want everybody to recognize is it's organizational and patient-directed exchange of information. The patient is the one who's going to enable interoperability by leveraging their trust in the system. If we lose that trust of either the frontline workers or the patient, we're going to lose the benefits that interoperability can provide. Some of the other challenges we see is interpretation. Each of you are probably participating today in a series of events that drive better requirements around what health IT is supposed to do in the future. I want you to look around and find and determine if you're asking the questions, how would we test that? The common approach to testing that we see across numbers of different standards is happy path testing. Ideal system, perfect data, system works, ship it. And we think that the frontline care providers, they deserve better than that. we see very limited to no exception, negative testing, exception level testing. And we think that's important too. What should the system do when there's an error? Those requirements, we don't take a lot of time with those, and we need to. And also, as I said earlier, we need to prepare for it. There will be changes. There will be multiple versions of standards, multiple versions of fire profiles and implementation guides. The operations of those production systems are going to depend on our ability to understand which version of software we're dealing with and which version of endpoints, geeky stuff. But we have to recognize that change will happen. We do not want these production systems to fail overnight because a participant, an organization that we were exchanging with yesterday, happened to upgrade and we didn't know it. The standards bodies, we believe, are going to be put under new intensive pressures. HL7 and Fire, we're working really hard. 4.0.1 is out right now in production and people are implementing to it. And version 5 of Fire is under development. We're very excited about the new advancements and more normalization happening. Really good things happening, but change is inevitable. So how can we mitigate these risks that we see to interoperability? We know that it's important. We don't have to talk about why interoperability. We all know that, but we have to say, will interoperability work at all times? And that's what I want everyone to take away from my talk here today. So standards-based organizations that are advancing these concepts of standards and requirements, we really need to be able to provide some feedback to them on how well their implementation guides are doing. And programs like DaVinci here in the US and programs that we're working with the ONC and CMS, they recognize that as the implementation guides for fire are being built, as these requirements are being built, they need to be tested, because it's not about the first organization that implements a standard. It's not about the 100th organization that implements a standard. It's about 1,000 organizations all implementing the standard the same way. That's the way we achieve interoperability. And we can mitigate that through TDD, test-driven development, embracing test early, test often, and again, making it part of our continuous process. So in closing, interoperability only works when health IT systems are highly conformant. And you'll hear us talk about, whether or not a fire server is compliant or capable, what the conformance statements are. And the idea is that we believe that the industry as a whole needs highly qualified systems, highly capable and highly conformant. So I'll pause there. Thank you, everyone. I appreciate the time today, and I hope this has been enjoyable. Amar, back to you.
Thank you, Mario. Couple of quick questions from me. The first one is that we heard earlier about the efforts in Europe going on. How do these efforts relate to the ones going on in Europe and in other places at this point?
So with respect to interoperability, what we see now at a standards level is that as people are looking towards interoperability and being able to coordinate patient care and being able to get that information out to the industry as quick as possible, standards appear to be the way to go. And whether that's a vocabulary server supporting SNOMED, whether that's a fire implementation to support client-directed exchange like we see with NICTIS and MedBay, Fire, HL7 Fire, is being viewed as the standard that people should be looking towards, and they're going through early adoption. This is a process by which we engage with the industry. Please make no mistake about it. We need everyone's support. We need clinicians on fire. There's an organization within the HL7 Health Level 7's industry that's specifically designed to help clinicians understand how to get their requirements built into the standard. So we definitely encourage everybody's participation, because that's the way we're going to advance this. I hope that answers your question, Amar.
Yeah. When we did a study and we came across over 100 initiatives going on around the world in the area of healthcare interoperability. Some of them are very domain specific, like for one particular medical specialty. Some of them are regional, limited to one country, and some countries have done very well Israel, for example, has done a lot of work which is very homogeneous, so they don't need blockchain or others to do it because it's a unified system. So what I find right now is that people are interested in it. They're developing different things. And also within this area, I should mention, there's the activity from a billing point of view. The nursing systems are very different in different countries, even across different hospitals. There's no standardization in many places. The IoT devices are using their own ones. The imaging data have been using DICOM for a long time. That has been the one where industry and all. So these things, people are interested in it, but I also see a sense of people feeling that what I'm doing is the right way to go and others should go ahead and adapt it. And we did earlier work on interoperability in other sectors. And it basically came down to who had more power, whether it was the supplier of the data or the receiver of the data who determined. If you're submitting a tax return to IRS in the US, you have to give it in the form that the income tax wants, not the other way around. Whereas if you're in the stock exchange gives you the information which you want. So at this point, a lot of money is being poured into this area, but I don't see any global leadership initiative, which I really recommend at this point. I see it all a fragmented approach, and I don't see anybody playing that role, either the World Health Organization or a European agency. I don't think anybody in the US is trying to look at a global thing. They're just saying that what we do here, the rest of the world will adapt it. That's more of the philosophy which is going on. How do you see we are going to take care of it? And by the way, I should tell you that I faced this problem in other areas in defense sector, in check processing. And in those areas, I found that it was actually a crisis which had actually led to something being solved. We were trying to do it in the check processing area. There was no synergy, but 9/11 is the one which acted as a catalyst for it. Similarly, in the case of defense, it was the Grenada War which helped to integrate records of Army, Air Force, and Navy. Now that COVID has come in, how do you see it framing under the current circumstances? Do you think the world will unify or take a unified approach at this stage?
That's a great question, Amar, and you're absolutely right. Nothing drives us better than a crisis, and COVID-19 is definitely something to look at. I would offer that watch WHO, watch what happens with the global immunization efforts around the country, around the world. You're right. There is a lot of focus right now, especially with HL7 fire, just as an example, as one standard. But there's a lot of localized, or what we call realm, like US realm, or what's happening in Canada. Ontario is doing some great work, getting ready for some implementations around HL7 fire. But you're right, as far as a global initiative to enable the implementation of a particular type of use case that has global reach, well, I would point to GA4GH, the Global Alliance for Genomics Healthcare. They're looking at some global solutions, and I think that organizations like the Broad Institute, which has works with MIT or is part of MIT, they're doing some great work with GA4GH, but it's all very much in the early stages. We're trying to get interoperability to work. We're trying to get a global perspective. We're trying to work on smaller use cases. And I think right now, the biggest one that we could work on is getting an immunization program in place that would enable WHO to track the globe as we immunize against COVID-19. I hope that answers your question, Amar.
Yeah, I worked for the World Health Organization before, and at least at this point, I do not think they can play this leadership role, partly because the US wants to leave the WHO. They don't have that level of support. So it might be the rest of the world versus the US, just as happened in the measurement system, where the rest of the world uses metric system. The US is one of the 3 countries which still doesn't use the metric system. So we might have things of that nature. But turning gears a little, if I may, and I'm familiar with some of the work on genomics and other areas. These islands of information are coming along, but these islands can only be bound together if there's some bridges across these islands of information. The opiate industry is going in one way, the pharmacy industry is going in another way, the health IoT devices are going another way. And in order to have a road or a bridge which is there, you need something which is really acclaimed or which is actually respected by a lot of people. And the VA Vista system could have potentially done something like this as being a vehicle for carrying this thing, but that has now been dispensed in favor of Cerner, so that's no longer an option. So I see the options actually going away rather than coming to the fore. I also see major problem that when we have this data, if we are going to use it for revalidation of devices, revalidation of software and all. We need software, and nobody is using that software at this point. The results from this data, from real patient experiences, patient-reported outcomes, how do you deal with missing data? How do we deal with conflicting data? These are some of the major challenges which are coming in, and people realize these challenges, but I don't see any effective way of dealing with any of these issues at this point. And the thing which I wanted to suggest based on my past experiences, these things cannot be done in isolation. The people who are actually leading these different initiatives, they should all be coordinated under a common umbrella to really do something useful, which will really make it work. So we need a super alliance, if I can use it, or a super consortium under the aegis of World Health Organization or some other agency, or an agency specifically set up for this thing, like the W3C, for example, did it in the area of internet, which essentially started from Europe as a thing, Tim Berners-Lee when he was there. So I'm just saying that this is an area where the academia, the government, and the industry need to work together. How would you react to an observation of this nature?
So Amar, I think that's a great initiative. I look forward to you leading it, and I'll be there to help you.